Hi, good morning, everyone. I'm Jessica Kelly. I'm one of the members of the legal team at Mayo Clinic. I'm based out of their Jacksonville location, but support their enterprise campuses, so across Arizona, Minnesota, South and Northwest Wisconsin, and then Jacksonville, Florida. My expertise is in regulatory compliance and bioethics, as well as clinical research. And one of my areas that I support Mayo in is opioid prescribing and providers protecting their licenses when they're prescribing opioids or supporting patients who are having chronic pain and other issues. Can you see my slides now?
No,
Just
I think you'll have to reshare them.
Okay.
There we go.
So this morning I'll go through a few various learning objectives, covering potential legal implications of opioid prescribing, talking through some special considerations when prescribing opioids for patients, detailing current state and risks of telemedicine prescribing, and then talking through some of the risk mitigation strategies when working with various patients that are on opioid regimens. So I'll start with the very scary risks. Essentially, there have been an uptick in criminal prosecution cases of patient deaths related to overdose, any kind of pill mill legislation. You've seen that over the last several years, and a lot of prosecution related to those that are over distributing or over prescribing opioids and have operated very dangerous operations where they're prescribing to many, many patients in one day. They don't have good documentation around conditions. They're not supporting those patients well, and it's led to a lot of the opioid epidemic issues in America. So there's been a lot more attention to those cases and the criminal prosecution of those physicians or other providers like pharmacists who help facilitate those types of trafficking and distribution rings over the years. There's been a case that's gone all the way to the Supreme Court too that talks about prosecution of those types of cases and physician discretion and whether or not physicians have responsibility to prevent this type of abuse. There are additional legal risks as licensed practitioners that you'll hopefully not encounter over your time, but should be aware of. We've seen an uptick in malpractice cases related to opioid overdose or death, or potential addiction related to post-surgical pain or treatment of chronic pain. So essentially, we have to make sure when you're working that you have the skills and tools to be able to meet the standard of care for prescribing opioids, that your practice has good practices in place to make sure that you're getting good documentation, that you're paying attention to patients that may be having issues with their prescriptions and substance use history, and doing risk assessments of those patients to avoid potential civil liability for malpractice related to your prescribing practices. There's also potential licensure risk where there may be a complaint by a patient or family member. You may fail to meet requirements for checking the prescription drug monitoring program in your state. There are other areas where you could be disciplined for your prescribing practices related to opioids and other controlled substances, although there's been lots of attention to opioid prescribing over the last several years. There's also other reciprocal discipline. You can lose your DEA prescribing authority. You can be disciplined if you're licensed in multiple states for violating board rules of other states. You can be excluded from participating in government payer programs, which would then really inhibit your ability to practice. And so want to just highlight those things to make sure that there's good understanding of potential risks when prescribing these medications, that you can have potential impacts to your license and your livelihood to practice. There are also institutional risks to the organizations that you work for. Some providers are operating under institutional DEA permits when they're administering medications in their facilities. And that's where a lot of the prescribing starts or dispensing starts with patients, is when they're inpatients before they go home post-surgery or something like that. So they have to make sure that we're tracking for diversion. We're following CMS and Joint Commission recommendations related to pain assessment and other metrics related to our opioid prescribing practices and making sure that we're having compliance with the prescription drug monitoring programs before prescriptions are issued, that we're complying with e-prescribing requirements, other issues like that. There's also newer regulations related to excessive prescribing, and CMS also cracking down on looking at prescribing for patients that are under Part D for Medicare. So any opioid naive patients are going to be limited to a 7-day supply of medication. There'll be pharmacist review required if patients have higher than 90 morphine milligram equivalent prescriptions. And it'll also have other pharmacist alerts too. So there are additional layers that payers may be putting in place to look at opioid prescribing and look at your practices. Pharmacies are also required to check PDMP records when they're dispensing controlled substances or opioids. And these investigations can be resulting from that data. So if there are potential concerns, the patient may have issues filling their prescription. Pharmacists will also have responsibilities as a self-governed profession to report any physicians that they feel are over-prescribing or dispensing or have poor prescribing practices. And essentially, they're also on the hook to make sure that they're compliant with DEA regulations and whatever state level regulations that your state has regarding reporting and checking a prescription drug monitoring program. So I'll talk first about some special considerations for patients that you may be treating for chronic pain. And a lot of states have started to focus on non-opioid alternatives and documenting that you're assessing patients to see if they're candidates for non-opioid alternatives, if there's other treatment modalities that can be supplemented or tried along with opioids, or weaning a patient off opioids, and looking at functional treatment goals, working with pain medicine specialists if patients are on more complex regimens of combined or polypharmacy type of regimens, looking at a controlled substance agreement with patients. And some states have requirements for this, others do not, but it is always good to set sort of a rules of the road understanding with patients that may have prescriptions for chronic opioids or be on opioids for longer than 90 days to make sure that they understand that there may be additional screening or additional appointments that they need to attend before you're able to issue prescriptions for those medications on a continual basis. It's recommended that you see patients every 90 days with CBC prescribing guidelines to assess the continued appropriateness of their therapy and necessity of continued opioid therapy. And so there should be continuous documentation, essentially a risk benefit for that patient, their status on the level of their prescription, what modalities you're trying for opioid alternatives, what plan is for patient over time, and then just continued benefit of continued therapy if you're continuing to prescribe to them. And then a note on DEA, just that Schedule II prescriptions can't be renewed. So each prescription is a new prescription. You can issue up to 90 days at a time, but they should have fill dates to say you can fill this one in 30 days and then in another 30 days to cover the 90 days. And giving 90 days at one time is essentially risky, and patients wouldn't be able to fill that at most pharmacies. There was better attention to some of the telemedicine requirements prior to the pandemic, but since we've been in the pandemic state for the last 4 years, a lot of the requirements at the DEA level are still waived. That will end up changing this year. So we're hopeful that once DEA works on their go for it, there will be some telehealth allowances for prescribing that aren't as cumbersome, where there's a required in-person visit before prescribing controlled substances. We will still recommend for opioids that you have seen patient in person before prescribing opioids if at all possible, especially if it's going to be beyond an acute short duration dose. And we think there'll still be additional guidelines around opioids, but they'll broaden this for other controlled substances where we do have issues with requiring in-person visits before prescribing, like for seizure medications or other lower risk controlled substances. But right now there are waivers to the Ryan Hyde Act that are not requiring that visit prior to prescribing an opioid or controlled substance. And these waivers have been in place for some time. The state DEA registration have also been waived until near the end of this year. So those things will come back into place, and we're hopeful that the DEA will implement the telehealth registration with rules around prescribing via telemedicine. But I would just be cautious when prescribing via telemedicine to make sure that the assessment that you're able to do through that modality is able to meet the standard of care. And if you're not able to assess the patient adequately to determine your prescribing practice, if you're going to prescribe opioids, that you ask that they attend an in-person visit to protect the patient and yourself from potential risk related to that prescribing. I'll go through a few case studies that we see, and some of these are sort of multi-layered where I've combined a few circumstances, but they are often questions we get about looking for red flags related to potential abuse, or if a patient should be screened for a substance use disorder. So on this one, it's where a patient is consistently requesting early issuance of new prescriptions or different opioid medication. They're saying that their medication isn't working. You suspect that the patient may be taking more than the prescribed dose or diverting medications. How do you manage that situation? So we recommend that patient would come in for a follow-up visit. If you feel that they need a bridge supply to avoid withdrawal, prescribe the shortest bridge supply you can. So even shorter than 3 days, if they're coming in 2 days, or they're able to come and they only need a small bridge to make the appointment. And then have patient bring unused medication and count medication in front of you. We don't recommend that providers count the medication. We recommend that they have patient count it in front of them because of DEA rules around taking back medication. So to avoid sort of accusation of diversion on your part or anything like that, we advise that our providers have the patient count in front of them. And then if they've misused the medication, we counsel them on how it was prescribed. If you're issuing a new prescription, having a mechanism for them to destroy the supply that they have left in front of you and then dispose of it. We don't recommend that you take the medication back. And if they have excess medication, we don't recommend that they keep it either. So to issue that new prescription, ask that they destroy the remaining prescription. And then essentially that you should not take custody of those drugs because can't accept back prescriptions. And for most patients, we recommend that they just take it to a DEA drop box if there's one near them, or destroy it themselves. But for patients where we feel there's risk for them having additional medication, we recommend the practice of having them destroy. And then look at urine screening tests too if you suspect that there's diversion or they're not taking the medication appropriately. The next case study is related to the doctor shopper, where you're looking at PDMP history and discovering that patient is getting controlled substances from several other providers. So patients that are on chronic pain prescriptions specifically, but any combined controlled substance regimen, typically we ask that they get all their prescriptions from one provider. If they're seeing specialty providers, just that they're coordinated and if they're prescribing different medications. But looking at controlled substance history, you're seeing that they are getting prescriptions from other providers, making sure that you inform them if they have a controlled substance agreement, that they're violating that agreement. You can urine screen them if you feel they may be diverting medication or overusing medication. And then if they need acute prescription for, say they just had surgery, but they're also on a chronic pain regimen, making sure that you're referring them back to their prescribing provider after that acute episode, or for a high-risk patient, coordinating with that prescribing provider for their chronic pain. And then if you're making a decision not to prescribe and the patient is saying that they're going to report you, they're upset with you, they're going to file grievances where they can because you won't prescribe the medication, just document your decisions for not prescribing and being based on a PDMP history and just risk of patient to overdose or other health condition related to that prescription. We also have the case study of the diverter where the patient informs you that they're selling opioids or they're buying opioids off the street that are potentially adulterated. And so in this instance, we typically advise that you counsel the patient on their controlled substance agreement or any parameters you have around their prescribing, that if it's high risk and physician feels that the behavior is pervasive, patient's not going to stop using street drugs, that they're referred for substance abuse counseling and consultation, and that they may be terminated from practice if they're not adhering to guidelines related to the prescribing. Document that you've informed them of risks of using street drugs, or fentanyl is the highest risk at this time, but there's other adulteration that's risky when you're using street drugs. And then if patient details egregious behavior like selling medications to high school students, or that they are essentially gathering street drugs and selling them, that you potentially report them to law enforcement. And that's where we would take the breach potentially related to that and rely on the law enforcement disclosures that HIPAA allows if patient is detailed that they are putting the community at risk with certain behaviors. And then just well-documented discussion in the record is going to be your most important protection.
Jessica, question. If a physician does contact law enforcement, can they do that anonymously, or do they have to share their relationship?
It'll depend on the law enforcement agency, I think, but they should be able to report anonymously or report through their security teams. If you work at a larger healthcare institution, we've had our security team also contact local law enforcement. Like if we'll discover a large supply of medication with a patient or something like that, we'll disclose to local law enforcement and then leave it to their discretion of how to investigate. But they may do further investigation and they would have subpoena power to then ask for records or talk to you to discover the physician was. So you don't have to disclose that without them issuing a subpoena or a warrant, but they will be able to discover that. And it's usually easier just to cooperate if they're asking for that information initially. And then it would be minimum necessary disclosure from a HIPAA perspective to make sure that you've reported any unsafe behavior, but we don't have to disclose full records or things like that.
But HIPAA and 42 CFR don't prohibit that?
No. So there are allowances for law enforcement disclosures.
Thank you.
Sure. So here are some of the legal risk mitigation tools. We've talked through some of them already. The big one that we talked about quite a bit is patient misuse risk assessments and what tools there are. There's industry standard tools. We encourage use for patients that are on chronic medications and continuing to have various needs related to chronic opioids or multiple controlled substance prescriptions. So looking at the CDC's opioid risk tool and looking at their risk of misuse or abuse, using psych assessment tools to determine if they have concurrent mental health issues that they may need counseling for or therapy for or referrals for that type of treatment. Just continuing to look at PDMP history whenever you're prescribing and really paying attention to patients with the concurrent prescriptions if they have prescriptions for benzos or sedatives or muscle relaxers, and inability or unwillingness to wean off of medications that they may not need when they're also combined with opioids, which are very high risk for overdose. Looking at clinical necessity of escalating doses and trying to taper back doses where a patient may not need that high dose any longer. And then if patients disclose use of illicit drugs, just factoring that into your risk assessment. It's one of the things that you want to balance, where we can't promise patients that we won't document their use of illicit drugs or not essentially factor that into assessment related to prescribing. So you want them to be forthcoming with us to protect them and our practice related to that drug use, but also need to make sure that it's clear that there's counseling on that illicit drug use and they're referred for treatment or counseling for substance use disorder if they're flagging high on any of these abuse risk tools. And illicit drugs going to flag a very high rating on the risk tool. So that would be something that we recommend documentation and referral of. And we have providers call after panicking to say, I promised this patient I wouldn't document this drug use. And then they're realizing they have to because it's material to their care and treatment and protecting their license. And so that's something I would recommend not promising patients, and it's documented as objectively as possible and accurately, but that you still make sure that that's documented in the record, and then your response to that information is also documented. Well, this is the CDC opioid risk tool, and any scoring on that that's high would just indicate high risk for opioid abuse. We talked a little bit about this early on, but just with the elimination of the data waiver intends to remove barriers to prescribing opioid use disorder treatment medications, namely buprenorphine. And so now with the expanded ability for many practitioners to be able to prescribe this for opioid use disorder, there should be a lot more access to this type of treatment, but a lot of prescribers are uncomfortable prescribing the medication or don't have robust practices where they are treating these patients. And there's training that's going to be required for all DEA registrants with their renewal. So by, I think, mid this year or maybe next year, every single practitioner should have had that training with their renewal of their registration. And there will be no limits on the number of patients that a provider can treat like there was with data waiver. But it's really getting providers the education and tools they need to be able to start prescribing these medications and understanding parameters around when it may be indicated and how to educate patients on the treatment and track and document appropriately on this treatment. And so SAMHSA has many, many resources on that, and making sure that our providers know that those are there, that they need to reference those if they have other questions, and then developing other education and training materials. This DEA training was something that we had a lot of sort of grumbling about throughout the whole practice for those that don't prescribe controlled substances often in their practice, or they don't treat patients for chronic pain, or other opioid prescribing practices are very limited or not present at all. But the intent is to make sure that all of our providers are educated on these medications, and if there were ever situations too where we had to have practitioners cross other practices, like a COVID situation, that was something that we had to address a few times during COVID with patients that were on a regimen. And then there were concerns about hospital prescribing because that had been the assumption for many years, that you couldn't prescribe or dispense medication while patient was hospitalized, and that they were limited to maybe 72-hour supply, and that there were only certain practitioners that could continue treating patients even if they were hospitalized. And so that's something that we've had to educate on too, with the changing of the data waiver, that if patients are on a withdrawal medication, that they can continue that, and then engage other practitioners who are substance use disorder treatment providers if patients are on methadone or other medications like that for treatment during their hospitalization. And then patient drug disposal, I talked to some about this already, but I stress this quite a bit because DEA has very strange rules around drug disposal and providers being able to take back medications, or pharmacists being able to take back medications, or even hospitals managing medications that may be left behind by patients. And so there are these DEA drop boxes that are throughout the US, but oftentimes not in all that convenient of locations. But the terror bags that are the drug deactivation bags can be purchased online, Amazon. There are other similar tools too that can be used to destroy medications where they can just be disposed of in regular garbage. And that's something that we recommend keeping on hand in your practice to make sure that you're protecting from any risk related to drug disposal. We've gone over most of this, so I'll skip this one. And then we talked some at the beginning about naloxone and Narcan and access to Narcan. Most states have started to expand access to Narcan where it can be obtained without a prescription, where there are protections for caregivers to possess it. Nasal Narcan is a lot more available now and available in a lot of grocery store pharmacies across the US. But I don't think that there's still enough education on when it may be indicated or necessary and when it may be helpful for just members of the community to possess it. So when you're looking at recommending or prescribing Narcan with opioid prescriptions, it's important just to look at whether or not the caregiver is present and can be educated on use of administration. Now that nasal Narcan is more available and not as expensive, we're recommending that in most instances. And anytime you feel like it's appropriate, you should just recommend that. It should be covered by insurance if you issue a prescription, and most states are now allowing pharmacists to issue a prescription if there's one needed to try to use insurance, or most states now allow caregivers to just purchase without any type of prescription. And there's protections for possessing it since it's no longer something that requires a prescription. And then just looking at co-prescribing guidelines that have been endorsed for prescribing this along with any prescription, or recommending that patient purchase it, and to allow caregivers or others that are around them to administer if needed. I've just linked some of the other tools related to prescribing for chronic pain, and then treating former addicts in the palliative medicine space. That's another one where we've gotten legal questions previously of how to navigate some of those situations with patients who need palliative care, transitioning into hospice, and they want to respect their status as a recovering addict, but also comfortably help them transition into hospice care or treat them with the best comfort care they can from a palliative medicine space. Here are some tools to protect your license. So maintaining controlled substance CME, always checking the PDMP, which I've probably said 10 times throughout this. Refer any of your high-risk patients to specialists, whether it's a substance use disorder specialist or pain medicine specialist that may be able to better manage their prescriptions and other modalities to treat their pain if they have nerve pain or other issues that have been managed by opioids but may be better managed by other types of pain management tools. If you're looking at patients or seeing that they're requesting subsequent prescriptions or refills for other controlled substances, and declining to prescribe or prescribing the shortest supply possible until you can see them in person is always recommended. Just really robust documentation related to these patients, because that's really all you're going to have to rely on if there's ever an inquiry from a licensing board or a grievance submitted to one of our regulators or an inquiry from DEA. They're going to rely on your clinical documentation. So even if you have really great practices, your clinical documentation is poor, you're going to struggle to go through a licensing board or inquiry from a law enforcement or a lawsuit. If you have poor documentation, you'll oftentimes be at high risk of losing that and risking your license or a large malpractice claim. If you become licensed in another state, just reviewing their controlled substance prescribing laws and CME requirements as soon as you are licensed there. I think it's very important. They differ state to state, sometimes very much, just depending on the type of practitioner. So I know there are some advanced practice providers on this call. Some states have psychiatric nurse laws related to prescribing. Some states prohibit other APPs that don't have that designation from prescribing certain medications or treating certain patients. So making sure you understand sort of limits in those states on prescribing with your DEA registration. If you're licensed in multiple states, you may have to take several state-specific courses in those states. And if you don't, you're risking essentially attesting that you've done education that you haven't done. That would relate to license discipline potentially. And then certain states have supply limits that go over and above DEA limitations. And so DEA is sort of the floor in most instances. And then states will have more strict prescribing requirements or information that needs to be on the face of a prescription for patients to be able to fill it, or requirements to check PDMP for all controlled substances versus only opioids or benzos, or there's some states that have less requirements to check, or it's not required, it's just permissive to check and they have it set up, but just making sure you understand those regulations if you're prescribing via telehealth in other states, or if you become licensed in other states and you're registering with DEA there. And also, just as cautionary tale, never let someone else fill out a license application or renewal for you, because those attestations are taken very seriously by boards and you can be disciplined or lose your license for misanswering questions on a license application. That is all I have.
And thank you for that, Jessica. A lot. Is there anybody has any questions? I know there had been a question up in the chat. But before I get to that, is there anybody has any questions for Jessica off the top of your head?